I'm Bill Bommer, and I'm here from Sacramento, California. And the presentation that we gave here at the meeting today was related to a program that we have in California looking at PCIs, or percutaneous coronary interventions, in individuals in the state of California. And when, as you know, PCI first started, it had a high risk. There was as many as 10 or 30% of individuals that might have a complication that would require emergency coronary artery surgery. And for that reason, all of the early trials and all of the early programs were developed within hospitals that had cardiac surgery on site or quickly available should a complication develop. Well, that was 40 years ago, and over the last 40 years, changes have taken place that PCI is now much safer to do. Very few patients go for emergency coronary artery bypass surgery, perhaps less than 1%. And in those situations, we may not need cardiac surgery to be standing by in the operating room for that PCI. In fact, most hospitals no longer have standby cardiac surgery in the operating room. And for that reason, we looked at California of starting a program where we would start pilot hospitals to do PCIs at hospitals where they did not have cardiac surgery immediately available in the building. In fact, cardiac surgery was only available by transferring the patient via ambulance to another receiving hospital, and hopefully that could be done within an hour or so. And in the program, we looked at 2 years of data and reviewed cases of over 100,000 PCI cases in the state of California, done at 116 hospitals that had cardiac surgery on site, compared with 6 pilot hospitals that had cardiac surgery off-site or would require transfer. And in those over 100,000 patients we looked at, we then did what was called risk adjustment, creating a model. And the first way we did that was look at our overall patient population, and we determined what risk factors contributed to that projected risk of a bad result, which would be mortality or death, or need for emergency CABG, which was our composite event rate. And when we looked at risk factors that predicted a poor outcome in that case, we came up with 22 to 24 risk factors that were associated with it, and things that you would normally expect, such as a patient in cardiogenic shock, much more likely that they would have a poor event or would have a poor outcome after PCI. Things like requirement for intra-aortic balloon pump, things like renal dysfunction, things like elderly age might predict it. When we looked at those individuals of the over 100,000 patients, we found about 2,000 individuals in the state in the last 2 years that had a poor outcome with PCI, and then we did the risk adjustment for it. After risk adjustment, what we found was that the overall event rate was very similar for the pilot program with off-site surgery as it was with the standard hospitals that had on-site surgery. In fact, for all comers, the mortality in individuals at the off-site hospitals was about 1.58%, and it was slightly higher at the on-site hospitals, but there was no statistically significant difference between those after risk adjustment modeling was taken into account. If we looked at the individuals who had STEMI excluded, that is, they did not have the procedure for a primary PCI for a STEMI, then the risk was even somewhat less, and it was almost identical at 1.15 to 1.16% in both the off-site hospitals and the on-site hospitals, showing that in California, under a very strategically set up and designed program for off-site surgery, it could be performed as safely with similar outcomes as PCI is done in hospitals with on-site surgery in the state of California.